Okay, welcome to our second class of aphasia. What we've learned until now is basically the essential anatomy and physiology of the brain and the nervous system. And what we're going to do today is talk about what happens when it goes wrong. What happens when things happen that we don't want them to happen, but yet we know that these things do occur, and how these things are likely to then cause aphasia. We're going to begin by discussing what is the single largest or most likely cause of aphasia, and that is stroke. Stroke is known by its more technical name, cerebrovascular accident, shorthand is CVA. Stroke is the third leading cause of death in the United States. It follows only heart disease and cancer. Cancer is number 1, by the way, heart disease number 2, and stroke number 3. A stroke can occur anywhere where blood flows within the area of the brain or the brain stem, okay, in the central nervous system. It causes death more often in women than in men, although it occurs more often in men than it does in women. We're going to talk a little bit later more about incidence figures and whom is more likely to have a stroke. What are the things we can do to prevent perhaps from having a stroke? What are the things we can't do? It would be nice to be able to control everything. Unfortunately, we know that that's not possible. The factors that increase the likelihood of a stroke are things like use of tobacco, specifically cigarette smoking, physical inactivity, I guess what we call couch potato behavior, atrial fibrillation, which being heart disease of some sort, and what is often known as the silent killer, and that is high blood pressure, more technically known as hypertension. Stroke occurs, as this chart shows you, and you can spend the time to try to decipher this. It's not critical that you know every iota of this kind of a chart, but it's here for you in case you'd like to look at it more carefully. And what you see is that until the mid-70s, early 80s, stroke is more likely in men than it is in women. But then there's a shift. After around the age of 85 or so, it's much more likely in women than in men. And that's simply because there aren't as many men around after that age. I guess for those of you who are listening to me, that's good news for you. Not so good for me, but I guess we'll all have to deal with that. And so stroke is more likely to occur in women than men as we get much older, and simply because there are that many more women. Okay. Stroke occurs when brain tissue is permanently destroyed, or at least temporarily does not function, due to decreased or absent blood supply to the affected brain tissue. So something is getting in the way of the blood getting to the brain tissue, and then the brain tissue is going to die after a while. It needs oxygen, it needs nutrients, and that's delivered by the blood. So some terms that we will run across and we should define: anoxia. A always means absence of. Anoxia is complete lack of oxygen to a cell. Hypoxia is partial loss of oxygen to a cell. The brain, which is not a huge organ in our body and really weighs somewhere between 2 and 3 pounds, I think, if I recall, consumes 20% of the oxygen taken in by the body, which is way beyond its proportional size and weight, and can survive 6 to 8 minutes without oxygen, but not more. When brain tissue dies, it is dead, and it gets reabsorbed by the body. It's no longer functional as brain tissue. That's a pretty final statement. There are a lot of public relation strategies that are going on, efforts that are going on in the United States and the rest of the world as well, warning signs of stroke. And so I'm going to share some of these with you. Something that we, first of all, as individuals should know about. Second of all, as caretakers of individuals who likely have had strokes, we should know about these things as well. And so one of the neat things that the New York State Department of Health has put out is something whose acronym is FAST, and the F stands for face. And then the question is, does the face look uneven? Okay. What are we seeing? We're seeing asymmetry of the face, which would indicate that there is some nerve damage, some disturbance to the nerves to the face. Arm. Is one arm hanging down? Again, we're seeing some difficulty with arm movement, with muscle tone, on one side specifically. All these things are on one side, and that's the most typical. Not always. Strokes can be bilateral, by the way, but more often than not, they're unilateral. The S stands for speech. Is speech all of a sudden slurred? What they're not including in this, by the way, is what about if speech is perfectly clear, but it's not sensible anymore? And that happens. We're going to see later there are definitely types of strokes that will result in types of aphasia that will cause no disturbance in the clarity of speech, but terrible disturbance in the integrity of speech and what is being included in the language. And then the T is time. It's time to call 911. Okay. The word ischemic is being introduced in this slide, so I'll define it now. Ischemic is a type of stroke where blood supply is blocked. It's occluded. It's occluded. Blood supply is blocked. There are different reasons, and we're going to see that, different types of ischemic strokes, but what all ischemic strokes have in common is that the blood supply is occluded. It is blocked. It no longer can pass through the artery. Risk factors for ischemic stroke include being overweight, lack of exercise, heavy drinking, hypertension, sleep apnea. Sleep apnea is it's disturbing to sleep, obviously, but more than that is it causes a cessation of oxygen flow. Not total, or no one would wake up, but it certainly messes around with the oxygen flow, and that's not something we want done. Illicit drug use, we're not talking about prescription drugs, but illicit drug use, smoking. Besides the cancerous issues of smoking, one of the immediate issues of nicotine is it's a vasodilator. It makes the blood vessels narrow. If the blood vessel is narrower than it should be, then it's more likely that it's going to be occluded. So that perhaps a very small clot may be running through your arteries and it's running unimpeded, but if you make the artery narrower yet, then all of a sudden it will be impeded. And so smoking certainly has an effect on stroke. High cholesterol, we're going to see later the dynamics of that, but what that does is it builds up within the artery, so effectively it makes the artery more narrow. Even though from the outside it looks like it's the same, but on the inside the lumen, the opening, is just that much smaller. Cardiovascular disease tends to throw off clots. We're going to get a better word for that later on. And diabetes. Diabetes is not ostensibly related, but yet we find that if we look at 100 patients who have had strokes, we're going to find a far higher than normal proportion of individuals there who have a history of diabetes. These factors, amongst others, are factors we can control. We can actually do something about it. We can do something about high blood pressure. Okay? There are lifestyle changes that will improve our blood pressure situation. There are dietary changes. There are medical changes. But there are things that can be done to manage high blood pressure so that it's not high. We can do things to manage cholesterol. Now, there's no question. There are people who are born with high cholesterol. They didn't do anything wrong. That's a small population. The larger population of people who have high cholesterol did it to themselves. It's a matter of diet. But in any case, there's something that can be done to manage it. Can we get rid of all these problems? Probably not, but we can manage them. We can minimize them. We can do things to control diabetes. We can do things to control diet and physical activity. We can do things to deal with overweight and obesity, and we certainly can stop smoking, or never start, even better. So these are controllable risk factors. What's that all the risk factors were controllable, but they're not? What cannot be changed? Well, age. At your age, I tend to think you're not thinking about that a whole lot. At my age, perhaps, I'm looking at a typo right now. Okay, on the second line, that's each decade, not EACG. The chance of having a stroke approximately doubles for each decade of life after 55. And so whatever the risk factors, whatever the odds are for you at the age of 55, they're twice as bad at 65 and twice again at 75 and so on and so forth. But we can't do anything about age. At least nothing we want to be able to do. Heredity. If a parent or a grandparent or a sister or a brother, blood relatives, have had a stroke, then that increases the likelihood that you're going to have a stroke. African Americans have a much higher risk of death from a stroke than Caucasians do. Doesn't mean they're necessarily more likely to have a stroke, but they're more likely to die of a stroke. And that's partly because, at least that's what the thinking is, because African Americans are known to have a higher risk for hypertension, for diabetes, and obesity. And we know that those things are risk factors for stroke. We mentioned gender before. Stroke is more common in men than it is in women. Men are more likely to be hypertense. Men are more likely to be overweight. Men are more likely to be inactive. And so all those things go into it. It's not particularly the X or the Y gene. It's the behavior of a man. Okay? Although, frankly, the numbers, the inequality between men and women has been diminishing over time. That probably has to do with changes in lifestyle. If you compare women's lifestyles in 1950 compared to women's lifestyles in the year 2015, it's vastly different. Women were much more likely 50 years ago, 60 years ago, to be stay-at-home women, certainly with tensions of taking care of a home, but not the tensions of workplace, not the tensions of schedules that were as tight, not the intensity of employment. But now that, women are far more equal, they get all the bad stuff that comes along with it, unfortunately. What else can't be changed? Well, again, along with the men-women issue, more men than women will have a stroke in a given year, but more women will die of strokes in a given year. That's partly because, not because they're more frail or the strokes are more severe, it's partly because the women tend to be much older when they have strokes. Remember that blip we saw before, where over the age of 80, 85, it's mostly women who are having strokes. Well, then they're more likely to die. Even if they didn't have a stroke, they're more likely to die at that age. Something that's unique to women is the use of birth control pills in pregnancy pose a specific stroke risk. Now, that doesn't mean, I don't want panic in the city. People who are taking birth control and people who are pregnant and having children are not likely to have strokes. But it does increase the likelihood a little bit. For sure, if you're being well prescribed and you're getting good medical care, these things are not going to be of issue and should not be of concern. You just have to do what medicine tells you that you should be doing. The other risk factor that you can change is if you already had a stroke, or if you already had a transient ischemic attack. We haven't defined that yet, but we will. Or if you've already had a heart attack. The risk of stroke for someone who has already had a vascular incident is much higher than a person who has not. Okay, we're going to stop at this point and move on.